Hi, I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to this solid anatomy lecture on the deep back. In this video, we'll be focusing on the bones, joints, and ligaments of the spine. Now, I'll be back a little bit later for some clinical correlations and then for the end of session quiz. But to start things off, I'm going to hand the lecture over to our guest educator, Dr. John Phelan.
Over 97% of all animal species are invertebrates. Invertebrates living in the water are able to move around rather well and attain large body size because the buoyancy of water helps support their bodies and their limbs. Terrestrial invertebrates don't have the buoyancy of water helping them to resist gravity. So with only muscle to assist them in retaining their form and supporting their weight, they mostly lie full length on the ground, slug-like. That's where a vertebral column and a skeleton come in handy. They enable an organism to raise its head and its belly off of the ground and engage in rapid locomotion. You're probably aware that human beings are vertebrates, meaning they have a vertebral column, or spine, helping to support their body weight and to protect their central nervous system. The skeleton may be divided into axial and appendicular components. The appendicular skeleton is made up of the bones associated with the appendages, meaning the arms and the legs. When you hear axial skeleton, think axis because it consists of the central bony elements of the skeleton, namely the skull, the sternum, the ribs, and of course, the vertebral column. The vertebral column is made up of 33 vertebrae, which may be grouped into 5 categories. There are 7 cervical vertebrae associated with the neck, 12 thoracic vertebrae along the posterior aspect of the thorax, and 5 lumbar vertebrae posterior to the abdomen. These vertebrae are often referred to by just a letter and a number. That is C1 through C7 for the cervical vertebra, T1 through T12 for the thoracic vertebra, and L1 through L5 for the lumbar vertebra. The next 5 vertebrae are usually fused to form the sacrum, which articulates with the hip bones to form the bony pelvis. The final 4 vertebrae are fused to form the coccyx. When viewed laterally, the spine is not perfectly straight, but rather has 4 curvatures. The anteriorly concave curvatures at the thoracic and sacral levels, which are seen at birth, are labeled kyphotic. The posteriorly concave curvatures at the cervical level, which develops when a baby begins lifting its head, and at the lumbar level, which develops with standing and walking, are labeled lordotic. Here are the features of a typical vertebra. Anteriorly is a broad mass of bone called the body. The bodies of the vertebra increase in size as one moves caudally along the vertebral column because the bodies are the weight-bearing portions of the vertebra. Vertebrae near the caudal end of the vertebral column have more weight to bear than those near the superior end of the body. For instance, the cervical vertebrae support the weight of the head, but not the weight of the upper extremities or the ribs or the muscles attached to the ribs, etc. Posteriorly is a vertebral arch consisting of bilateral pedicles and laminae. The pedicles are short cylindrical processes between the body and the lamina. The superior and inferior notches on the pedicles of adjacent vertebrae form the intervertebral foramina, through which the spinal nerves exit from the vertebral canal. The lamina continue posteromedially from the pedicles and meet at the midline. The posterior arch and the posterior margin of the body of a vertebra form the vertebral foramen. The sum of the vertebral foramina is the vertebral canal, through which passes the spinal cord.
Welcome back. Since we're discussing the features of the vertebrae, let's spend a little bit of time talking about a surgical procedure called a laminectomy. Now, the term laminectomy refers to the surgical removal of a segment of the lamina to access a structure in the vertebral canal, such as the spinal cord. The vertebral arch can be removed via transection of the pedicles or by transection of the lamina. So this answers the question in your study guide. The vertebral arch can either be removed at the pedicles or the lamina. Laminectomies provide access to the vertebral canal, usually to relieve pressure on the spinal cord or the nerve roots. Often this pressure is caused by a herniated intervertebral disc, which we'll cover shortly, or the pressure could be from a tumor or from bony hypertrophy, excess growth of bone. After the vertebral arch is removed, metal bars and metal plates are often fastened to adjacent vertebral bodies for structural support. All right, that's it for this clinical correlation. Now let's pick back up with the lecture.
Several processes project from the posterior arch of a vertebra. At the midline, extending posteriorly from the junction of the lamina, is the spinous process of the vertebra. The vertebra with the most prominent spinous process, which is often palpable, is the vertebra prominens. The seventh cervical vertebra, C7, is the vertebra prominens in about 70% of people, while either C6 or T1 is the vertebra prominens in most of the rest of the population. Projecting posterolaterally from the junction of the pedicle and the lamina is the transverse process. The spinous and transverse processes serve as attachment points for muscles that act on the vertebra, the skull, and other bones. The superior and inferior articular processes are vertically oriented extensions originating from their respective surfaces of the posterior arch at the junction of the pedicles and lamina. Each superior and inferior pair forms a zygapophyseal or facet joint, which is a synovial joint that helps keep the vertebra aligned. There are distinguishing features that allow an investigator to tell cervical, thoracic, and lumbar vertebra apart from each other. Cervical vertebrae have an opening in each of their transverse processes called a transverse foramen, or foramen transversarium. The vertebral artery passes through this foramen in all of the cervical vertebrae except for C7. Thoracic vertebrae are unique in that they articulate with ribs, so their distinguishing feature is articular facets on their bodies and transverse processes where vertebrocostal joints are formed. A lumbar vertebra is easily distinguished from cervical and thoracic vertebra because it has neither a transverse foramen nor any articular facets for the ribs. Other features of note are that thoracic vertebrae have heart-shaped bodies and small vertebral foramina, because the spinal cord is narrower at levels where there are no limbs, and lumbar vertebrae have large kidney-shaped bodies to bear more weight than the cervical and thoracic vertebrae. The first two cervical vertebrae, which are named the atlas and the axis respectively, are structurally modified to allow mobility of the head. The atlas has paired lateral masses to bear the weight of the skull, just as Atlas bore the weight of the world on his shoulders, allegedly. In place of a body and a spinous process, it has an anterior and a posterior tubercle. There is a groove on the superior surface of the posterior arch for the vertebral artery, which turns medially upon passing through the transverse foramen of the atlas. The superior articular processes of the atlas articulate with the occipital condyles. The axis is the strongest cervical vertebra. Its name is inspired by the fact that the atlas rotates upon its broad, flat superior articular facets, allowing the head to turn back and forth. It has a tooth-like process called the odontoid process, or dens, projecting superiorly from its body and articulating with the anterior surface of the vertebral foramen of the atlas, where there is an articular facet just posterior to its anterior tubercle. To prevent displacement of the dens and the atlas with respect to each other, which would put the spinal cord at risk of injury, the transverse ligament of the atlas spans its lateral masses and passes between the dens and the spinal cord. Sacrum is the Latin word for sacred. There are two schools of thought on why this bony mass of 5 fused vertebrae was thusly named. One, that it forms the posterior wall of the pelvis, and the sacred organs of reproduction are found in front of it. And two, that since it is usually the last bone to disintegrate following burial, that there is something sacred about it. The 5 sacral vertebrae usually don't fuse until after the age of 20 years. The fact that it supports the weight of the upper body and transmits that weight to the pelvic girdle accounts for its bulk. The anteriorly projecting edge of the body of S1 is the sacral promontory. The superior surface of S1, which is the base of the sacrum, has a pair of superiorly projecting articular processes that articulate with the inferior articular processes of L5. The tapering inferior end of the sacrum, which is the apex, articulates with the coccyx. The sacral canal in its center is the continuation of the vertebral canal. It opens into 4 anterior and 4 posterior sacral foramina that allow passage of the sacral spinal nerves. The sacral canal ends inferiorly in the sacral hiatus, a gap formed by the absence of the lamina and spinous processes of S4 and S5. The remnants of the inferior articular processes on the inferior margin of the hiatus form the sacral cornua, which can be palpated and thus aid in the estimation of the location of the hiatus when administering epidural anesthesia. The coccyx is the skeleton of the vestigial tail of the human. It consists of 4 usually fused vertebrae. Coccyx is Latin for cuckoo, which may evoke the image of the beak-shaped bony coccyx. The 2 main joints of the vertebral column are the joints of the bodies of the vertebra and the zygapophyseal or facet joints of the articular processes of the vertebra. The joints of the vertebral bodies are secondary cartilaginous joints, or symphyses. They have intervertebral discs that provide strong attachments between the bodies, provide shock absorption for the vertebral column, and allow for some movement between the vertebral bodies. Each disc consists of a central nucleus pulposus, the gelatinous remnant of the embryo's notochord, and a fibrous peripheral annulus fibrosus. There is no disc between C1 and C2, and the discs between the vertebra of the sacrum often ossify later in life. Anterior and posterior longitudinal ligaments, which run on opposite sides of the vertebral bodies from the sacrum to the upper cervical vertebra, strengthen the symphysial joints of the vertebral bodies. The anterior longitudinal ligament limits hyperextension, while the posterior ligament limits hyperflexion of the vertebral column. When excessive pressure is placed on an intervertebral disc, such as when a heavy object is lifted, the disc may herniate. That is, the nucleus pulposus may extrude through the annulus fibrosus. The lateral part of the posterior edge of the intervertebral disc, which forms part of the anterior wall of the intervertebral foramen, is not covered by anterior or posterior longitudinal ligaments. This exposed area is a common site of herniation. When the disc bulges into the intervertebral foramen, it may press upon a spinal nerve, resulting in pain. The joints between the superior and inferior articular processes of the vertebra are synovial joints. These facet or zygapophyseal joints have relatively loose joint capsules that allow for a wide range of gliding movement between adjacent vertebrae. Other ligaments of the vertebral column include the ligamentum flava, the interspinous ligaments, the supraspinous ligaments, and the ligamentum nuchae. The ligamentum flava, singular is flavum, are elastic ligaments between adjacent laminae. The high elastin content of the fibers of this ligament give it a yellow color, and flava is Latin for yellow. They resist separation of the lamina during flexion of the vertebral column. Interspinous ligaments connect adjacent spinous processes, while the supraspinous ligament is one continuous longitudinal ligament running across the posterior ends of the spinous processes from C7 to the sacrum. The ligamentum nuchae, which merges with the supraspinous ligament superior to C7, extends posterior to the spinous processes in the median plane, filling the lordotic cervical curve. Muscles of the neck and back attach to the ligamentum nuchae. The joints among the axis, atlas, and occipital bone of the skull are called the craniovertebral joints. The atlanto-occipital joints between the superior articular processes of the atlas and the occipital condyles of the skull allow nodding and sideways tilting of the head. The atlantoaxial joints between the superior and inferior articular processes and between the dens and the arch of the atlas together allow the head to rotate from right to left. The skull and atlas rotate from right to left as a single unit on the axis. The cruciate and alar ligaments and the tectorial membrane support the craniovertebral joints. The tectorial membrane is the superior continuation of the posterior longitudinal ligament from the body of C2 to the anterior margin of the foramen magnum. Deep or anterior to the membrane is the cruciate ligament. As its name would suggest, the cruciate ligament is shaped like a cross. It is made up of the transverse ligament of the atlas and a superior and inferior longitudinal band extending from the midpoint of this ligament. As mentioned previously, the transverse ligament spans the right and left lateral masses of the atlas, running between the dens and the spinal cord in the vertebral canal. The superior band attaches to the occipital bone at the anterior edge of the foramen magnum, while the inferior band attaches to the body of the axis inferior to the dens. The alar ligaments are anterior to the cruciate ligament. They travel from the lateral surface of the superior part of the dens to the medial edge of the inferior aspect of the occipital condyles. They limit axial motion or rotation of the head.
Welcome back. Now before we move on to the end of session quiz, I want to spend a moment discussing odontoid fractures or dens fractures. The odontoid process can easily be injured in a motor vehicle accident or other trauma. Patients who have fractured their dens may be found at the site of an accident with symptoms of quadriplegia, maybe some respiratory depression, or at the other end of the clinical spectrum, patients may walk into the emergency room just complaining that they don't feel like their head's very stable after a fall or an injury, or they may be holding onto their head with their hands to prevent any motion of their head. They may be unable to actively move their head, or they may have some sensory nerve deficits. This is one of those cases where you need to immobilize the patient's neck immediately if it's not already immobilized. A patient with a minimal injury can easily suffer irreversible spinal cord damage if their neck is moved. These patients need to be evaluated with a cervical spine x-ray and or a CT scan of the cervical spine before you perform any further physical exam. With most neck trauma, you need to look at a lateral cervical spine view and a posterior-anterior view on the x-ray. Now, if you watch the introductory video number 1, you remember that we call that a PA view, and that's named for the direction of that the x-ray is traveling through the body. So a PA, or posterior-anterior x-ray, is performed by putting the x-ray film here, and you direct the x-ray beam posteriorly so that the x-rays go through the cervical spine from posterior to anterior, or PA. Now, one other thing to be aware of is that to visualize the dens optimally, you need to get what's called an open mouth radiograph in addition to the standard PA view. The jaw and other structures can obscure the dens if the x-ray is taken with the mouth closed. So you do that same PA view, but with the mouth open. This is called an odontoid view. Without this odontoid view, you might miss lateral displacement of the dens that you can't see on a lateral x-ray. Also, CT scans are very helpful in looking for a potential dens fracture that might be missed on x-ray. So let's go over a few questions. A 32-year-old man comes into the emergency room complaining of head instability and neurological deficits after a motor vehicle accident. He's using his hands to support his head. What should you do next for this patient? The next step is going to be C-spine immobilization. And then the next question, what view on x-ray is necessary to assess for lateral displacement of the dens? You do that open mouth radiograph. So that brings us to the end of session quiz. So I want you to pause the video, answer the quiz questions in your study guide, and then we'll go through those answers together. All right, let's get going. First question, the portion of the C2 vertebrae that extends through the atlas is referred to as what? It should be easy, it's the dens, or the odontoid process. Next, which vertebral body in most people is the most prominent spinous process, or it's called the vertebra prominens? This is C7. Next, which type of vertebral bodies have an opening in each of their transverse processes called a transverse foramen? These are the cervical vertebrae. Next, which type of vertebral bodies have the smallest vertebral foramina? These are the thoracic vertebrae. Next, which vertebral body has paired lateral masses to support the skull? That's the atlas. Next one, which vertebral body is the strongest? It's the axis. Next, how many vertebrae fuse to form the sacrum? It's 5. Next, how many foramina are there in the sacrum, allowing for passage of nerves? So there are a total of 16 foramina. There are 8 on the anterior surface, 4 on the left, 4 on the right, and then 8 on the posterior surface. Again, 4 on the left and 4 on the right. Next, why is the ligamentum flavum yellow? Well, it's yellow because it has a high elastin content. Remember, flava is Latin for yellow. And the last question, what part of the intervertebral disc extrudes, causing a disc herniation? Well, it's the nucleus pulposus, which is going to herniate through the annulus fibrosus. So this is called a herniated nucleus pulposus. All right, now it's time for your mock practical. So we've provided some images for you to label. Labeling these structures in a time setting is going to help you get ready for your practical exam. So label the images and we'll be finished. Thanks.